I'm Parves Mantry. I'm the medical director of the liver cancer program at the Liver Institute, and I would like to thank all of you for being here. Not only that, I would like to thank all of you for entrusting your care and the care of your loved ones to our team. That certainly means a lot to us, and we are very appreciative of that. I would like to keep this as informal and as engaging as possible. So I'm not going to show you any slides. I wanted to give you a very general overview of what we do, why we do it, our team, what things we keep in mind, and what are all the tools in our armamentarium that we use to beat liver cancer. And I'd be happy to take any questions at the end. But first of all, I'd like to express my appreciation and gratitude to Certex for sponsoring this, Suzanne for being our spokesperson, and then our team of physicians that is here, as well as the team which is backstage. So Dr. Steve Cheng, who's the surgical director of the liver transplant program, Dr. Priya Kannan, who's an oncologist at Texas Oncology, Dr. Shahin, who's our interventional radiologist, who does most of our selective internal radiation therapy. Jennifer McRae, who's really the backbone of our, she's our tumor coordinator. She's our, she manages all the cancer care coordination at the Liver Institute. And many of you who are who do this backstage for us. So let me tell you first a little bit about our entire team of physicians, surgeons, oncologists, radiation oncologists, radiologists, surgeons that are involved in the hepatobiliary and pancreatic cancer program at the Liver Institute. We have 6 hepatologists, myself included, Dr. Jeffrey Weinstein, Dr. Abdullah Mubarak, Hector Nazario, Maisha Barnes, Adil Habib. They're all trained in different places, and we work together as a team as the hepatologists for the Liver Institute. We have 4 surgeons, Dr. Steve Chang, Dr. Alejandro Mejia, Dr. Richard Dickerman, and Dr. Carlos Fasola, and they are transplant and liver cancer and hepatobiliary and pancreatic cancer surgeons that work closely with us at the Liver Institute. There's a team of oncologists, and there's quite a few of them, but Dr. Kannan from Texas Oncology is only one of our main oncologists involved in the liver cancer program. Interventional radiology is a very integral part of our care. Dr. Shahin has certainly been very instrumental in taking the lead on a lot of these liver-directed therapies, and you'll hear more specific and technical details from him. There's Dr. Suzanne Slonim, who's our previous chief of staff, and she heads the radiology program. There's Dr. Anthony Goy, there is Dr. Justin Smith, Dr. Asim Bhandari, and they have a really good team of experts that perform this liver-directed care. We have a bunch of cross-sectional imaging radiologists, and it is this cancer, as you know, is diagnosed mostly on imaging. We hardly perform any biopsies, so it is very important to have a team of radiologists that are experts in cross-sectional radiology, and we are really fortunate to have that from Dr. Carla Anderson, Dr. Michelle Moat, Dr. Jean Beisert, Benjamin Hines, Robert Farrell, Duke Pham, and these are some of our radiologists who are extremely well trained in cross-sectional radiology. This is the team of physicians that is involved in your care, and most of the time this is backstage. So how do we orchestrate this? Every Tuesday we organize a tumor board meeting where we discuss every patient with active cancer that needs some kind of an intervention. and a majority of the time it is a primary liver cancer, sometimes people with colorectal cancer with mets to the liver, or cholangiocarcinomas and pancreatic cancers. That's the realm of our expertise that we discuss every Tuesday. And usually there's a member from each of these divisions of specialties that I talked to you about. We look at films, discuss amongst ourselves, and then we come up with a plan. This plan is then communicated to the patients through Jen and some of our physicians, as well as our mid-level providers, as well as nurses, to the patients and their families. And then we translate the plan through care coordination between the Liver Institute, oncology, interventional radiology, and so on and so forth. So that's basically how we put this together. And of course, it is these are difficult decisions, and there's a lot at stake. And we again appreciate and are grateful for the trust that you put into us to make these decisions. Liver cancer is a difficult disease to treat. Why is it so difficult? Because it encompasses two different problems. We are not just dealing with a cancer, we are dealing with a diseased liver. 90% of the time, liver cancer occurs in patients with cirrhosis, where the liver has lost its architecture completely and irreversibly, and because of that, it loses its function. So when we treat somebody with liver cancer, not only do we have to keep in mind the characteristics of the cancer, but also what's happening in the background with the liver. So how do we make these decisions? There's 4 things that we keep in mind when we are looking at somebody with primary liver or bile duct cancer. We look at the tumor characteristics, and our radiologists, interventional radiologists, and surgeons help us decide where the cancer is situated. Is it removable? Is it something that we can get rid of with a liver transplant? Is it something that we can burn with a microwave ablation tip? Or is it something where we have to give a embolization therapy like chemoembolization or radioembolization? So that's the tumor characteristic. After that, we look at what is going on in the liver. So what is the function of the liver? And we calculate different scores like the child score and the MELD score. And those things tell us how sick the liver is and how well it is able to withstand any of these therapies that we are going to administer. The next thing which is really important is the performance status of the patient. And this is critical. We talk about this. Liver disease makes people very sick, and they lose muscle mass. They have impairments in their thinking. They are not able to produce a lot of the important proteins that are required to keep fluids out of them. So they accumulate fluid in their legs and in their belly and things like that. So we keep in mind how bad the liver disease is, and certainly the patients who perform the best are those where we can control the liver disease the best, and those patients where the liver is performing really well tend to do really well with all these specific directed therapies. Finally, we look at what is causing the liver problem. Now, a lot of times this goes at the back burner, because if the liver is already permanently and irreversibly damaged, we can't really do a lot to bring it back except consider doing a transplant, which is a possibility maybe about less than a quarter of the time when patients come to us with liver cancer. But a lot of times, taking care of what caused the liver disease in the first place, specifically we have new treatments for hepatitis C, we have really good treatments for hepatitis B, controlling diabetes, high cholesterol, high blood pressure, weight loss, and those individuals who have liver disease as a result of a metabolic syndrome. All those things are very instrumental in preventing the liver from getting worse once we are able to institute these therapies and make them successful. So as you can tell, a lot goes into this, the decision-making process. It is sophisticated, it is complicated, and certainly at the end of the day, we all put together our expertise in our fields, and certainly a part of it is our experience and our instinct in certain situations. So that's how we put together a decision process for patients who come to us with this disease. Finally, what are the tools that we have? And you're going to hear about this more from the ensuing speakers. But we offer a very wide armamentarium of liver-directed therapies. From an interventional radiology standpoint, and Dr. Shahin will talk to you more about this, but we are fortunate to have selective internal radiation therapy, and we are the few centers in Texas who employ this, and we certainly have more experience in internal radiation therapy than any center in Texas. And I can very comfortably say that we've used it very extensively, very successfully, and I'm proud to say that in a lot of our patients who came with very advanced and very challenging liver cancers. We use transarterial chemoembolization as well as bland embolization. Our interventional radiologists are highly skilled in performing very selective embolizations where we can target only or as much as possible the affected part of the liver and leaving the rest of it alone, because as I told you, the background liver is already a little sick, and we want to try and not to hurt the part of the liver not affected by the cancer as much as possible. And that's certainly a very challenging and sophisticated issue, and our radiologists are able to do that very, very effectively. We use microwave ablation very, very well. And this is very effective in cancers which are about the size of a quarter or so. From a surgical standpoint, we have a unique expertise of doing laparoscopic resections and the hand-assisted resections as well as robotic resections, and Dr. Cheng and their team, Dr. Mejia, are renowned experts in that area, and have been able to treat a lot of our patients with these surgical techniques extremely well. We have really good oncology support, and Dr. Kannan and her colleagues at Texas Oncology are able to use the available chemotherapy for liver cancer as an adjunct to these liver-directed therapies. And we certainly have, by using our team effort, have pushed the envelope where sometimes the hope may not be as much to achieve very good results. Finally, the last frontier for liver cancer therapy is liver transplantation, and obviously it is the cure for cancer, because we not only take care of the cancer but we remove the diseased liver. It is easier said than done, and about a quarter of patients who come with liver cancer actually qualify for a liver transplant. And it has to be the size of the cancer, the location of it, the number of them have to fit particular criteria that are set about by the United Network for Organ Sharing for patients to be eligible for liver transplant, apart from all other things like having good heart physiology and good lungs and good family support and a lot of the other things. But that we certainly strive for patients where the cancer is not resectable to try and see if we can make patients eligible for a liver transplant, because that is the ultimate cure. So that's my spiel. I would love to take any questions, and thank you very much for your attention, for being here, and like I said again, for having faith in our team to take care of you. Thank you very much.
I'll ask a question.
Yes.
I know that a lot of friends and people that I know that started out with colorectal cancer and have mets to the liver, it seems like they do a lot of surgeries. My tumors are actually breast cancer that went to the bone into the liver, but they don't seem to do so many surgeries there. Is there a difference in the type of cancer and the meds and where it goes as to what they can do?
Yes, there's certainly a big difference. So in colorectal cancer, when there are mets to the liver, it is generally a more isolated disease where it is most of the time just in the liver, and the disease through chemotherapy has been eradicated everywhere else in the body, and therefore resection and in a lot of cases radiation or radioembolization through spheres is extremely effective. In some of the other cancers, especially breast cancer, is a more systemic disease, and therefore resection or selective internal radiation may not work as well as it does in colorectal cancer.
Can you explain to me a little bit when they do a PET scan and they show uptake of tumors in the liver, and they give it a number, like if it's a 12, they don't usually say what that means, how big it is or anything, and maybe it's shrunk to a 4, and it's always interesting when you get your results that you read all this, but you don't really know what that means.
Sure.
Take the SUVs.
Sure, and that is a little bit out of my realm of expertise, but I'll have Dr. Shahin and Dr. Kannan answer the question about the PET scan.
If you don't mind, just repeat that question one more time.
I'm just curious that when they do PET scans to check where you're at internally, and it tells where the uptake, usually in the tumors that you have, and it usually gives it a number, like it'll say it's 12.2 or it's 4.1.
So I'm an oncologist. So let me explain your question, going back to your question about the breast cancer with the lesions in both the bone and the liver. First thing first is we often do PET scans to see the activity of the disease. The PET scan is based on the premise that the tumor is very active, which means if it's very active, it takes up more glucose. Mm-hmm. And as it gets less active, it takes up less glucose. So the number may mean something. It may mean that it's more active. We have seen, of course, the uptake that you're taking. It's called SUV. You can have up to 20, 25, 30. So the number may mean something, but more relevant is how much it came down, meaning that you're responding to treatment. The PET scan is not great about the size because it's not a CAT scan. It's related with the CAT scan, but the PET scan is more definitive for how much the tumor is responding to the treatment. So it gives us some indication for that. So it basically means that you're responding to the treatment in terms of liver disease. Bones don't change very much with treatment.
No, bones.
The bones kind of tend to be the same, unless you have any problems, in which case you may see new lesions. If you see new lesions, then you may want to image it more closely in terms of an MRI or an X-ray or combination. In which case, if you have problems in the bone, you can do radiation. But if you're getting systemic treatment for breast cancer, and if your SUVs are coming down, the uptake is coming down in the liver, it basically means that you're responding. So you have a good tumor biology in terms of the fact that you're responding to that particular treatment. And
So
that's
it's not
what it
important
means.
to know size or anything when you get
Size matters as well, but the PET scan is not a great tool just for size alone. It's more a matter of how much your tumor is responding in terms of the uptake, meaning more cells are being killed at that particular spot, and that's what it signifies.
Can I ask one more question?
Absolutely.
Radiation, when you're talking about radiation to the liver, you know, a lot of times you can get scar tissue and whatever if it happens to get something that's not where they're aiming. But tell me, what's the possibility of that with radiation to the liver?
Sure.
Is it so close to other organs that they have to be very careful?
Sure. So there's two types of radiation therapy that we deliver to the liver, and one is through an external beam, and the second one is through radioembolization or sear spheres. And majority of the time what is used at our institute is radioembolization through the sear sphere. So this therapy is guided through a catheter which goes into the artery which supplies blood to the liver, and only most of the time those beads go to the tumor. So it is very, very specific and very directed. Therefore, the possibility of radiating other organs is almost nil. Also, and Dr. Shahin will explain this more, they take precautions to make sure that those radiation beads do not go to other internal organs. It does produce some scar tissue inside the liver. Most of the time that is not of much clinical relevance. Sometimes for our surgeons, when those patients undergo a liver transplant, it may be a slight challenge, but majority of the times it is not an issue, and the possibility of radiating other organs is very low.